then the anterior mandible. Okay, now raise your hand if you think the posterior mandible is a difficult situation that you often have this problem. Anybody? Okay, so let's take a look. You know, there's a lot of cases in the posterior mandible that we have. And this is what we're going to get. For this to get, you need, again, three things. And one of the most important and most difficult thing is to get a healing like this. And so, there's a lingual flap, there's a buccal flap. And please look at the buccal flap. Do you see the nerve? I don't want to see the nerve. I don't want to expose the nerve. I don't want to separate the nerve branches. I want to leave the nerve alone. Okay? And that's one of the most important things. The other most important thing is to make the lingual flap also advance, the lingual flap. Okay, this is a dentist. This is on Thursday. This is on Monday. But I'm not very honest because that's an exceptional patient. Most of my patients have more swelling than this, but this patient didn't take a single pain medication. Also not, that's not so rare. Many of the patients don't take a lot of medications for pain. My average patient takes less than 5 pills. And I would say 85% of the patient takes less than 3 pills for pain. Even if they are American. So, how do we do it? We're going to create a flap. And this flap is going to be the safety flap. It's very important, the extension of the flap, very important, the vertical incision of the flap. Very important how we elevate this flap, which is sometimes, especially in Vietnam, a thin phenotype patient. So we have to be very careful. Then we do on the lingual. On the lingual we have the retromolar pad. We have the mylohyoid muscle. We have the mylohyoid muscle. We have a lot of anatomy that we have to know. Anterior part of the flap. We even use the back end of the blade. Once we advance the lingual flap, then we're going to scrape some bone, or we take a trephine to harvest some bone. Okay, I showed you what is the ratio. We're going to perforate. It's a very poor host, very cortical, so we need to perforate. Then we're going to take the membrane and fixate the membrane in the lingual. There's a pin here, and a pin here, and a pin here, or a screw. Now raise your hand if you feel that this is difficult. It can be very difficult, right, to fix it on the lingual. Now we're going to compress. And we're going to compress and compress and compact the bone graft like a dense filling. I'm going to raise this up. I'm going to fill it in more. So we have all this bone graft. Now we understand how it forms. But now we have to advance the buccal flap, and it's the nerve. And the nerve is very superficial, so we cannot cut deep. We cut very superficial. And then we do something which we call the debundling. And then we do a blunt stretch. A blunt stretch. This way we can close the flap in the middle first. First closure in the middle. because we want coronal positioning of this flap. We put in 3 mattress sutures. After 3 mattress sutures, some normal interrupted sutures are following. And this way, we get this band of tissue to protect this, but this has to be also very tissue friendly. It has to be thin because this flap is very thin. So metal here, like sharp or moving, is going to be problematic for the patients. And so we need to understand the anatomy first. Okay, the anatomy can be very complex and very complicated. You know, from our university, all these specimens, they sign a contract with the university when they're alive that they want to be a specimen. And after that, you know, there's an ethical committee, an approval, that this is ethical. Look at this, it's a digitalized cadaver. Look how nicely you can see the blood vessels, how you can travel inside. So let's learn first the anatomy before we're gonna do the surgery itself. Okay, the muscles, the vessels, the nerves. Okay, so first we have the carotid artery, and from the carotid artery, this is the linguofacial trunk, or truncus linguofacialis. And it has 2 arteries. One is the lingual artery, the other one is the facial artery, which is crossing the 12th cranial nerve. The lingual artery goes just above the hyoid bone. This is the hyoid bone, this is the lingual artery. Then it goes up and bifurcates, becomes 2 arteries. One is the deep lingual artery that goes to the tongue. The other one is the sublingual artery. The sublingual artery. This is an anterior view, a view from the anterior. This triangle is called the lateral lingual groove. What do we find in here? Let's take a look. The border, the mylohyoid muscle, the genioglossus muscle. The lingual artery comes behind the mylohyoid muscle, then it goes down here, and this is, the first branch, is the sublingual artery, which is under the sublingual gland, sublingual artery. Then we find here the lingual nerve. This one is the lingual nerve. And we find the Wharton duct. So we have 4 things. We have the lingual nerve, the Wharton duct, the sublingual gland, and the sublingual artery. Now everything, all this, is embedded in a very dense connective tissue. This connective tissue is so dense that it's very difficult to damage any of this. So when I'm preparing this, and you can see this is the dense connective tissue. And here is the lingual nerve inside the dense connective tissue. It's very rare that I see the lingual nerve, but I'm not afraid of it because it's all protected. Because this dense connective tissue was developed by nature millions of years ago to protect this anatomy from the dentist. See, when I'm in the zoo and I see a poisonous snake, the black mamba, behind a glass, I'm not afraid of it. This is the same thing as the black mamba. So there's another anatomical variation, which is this is the facial artery, this is the submental artery, and in 30% of your patients, it will have a ramus perforantes, a perforating branch that goes through the mylohyoid muscle and becomes the sublingual artery. Okay? You see here the mylohyoid muscle. Mylohyoid muscle is a very delicate insertion. We don't want to destroy this insertion. This is the diaphragm. We want to maintain this. Okay? So our goal will be to maintain this throughout the surgery. Levi, can you put on mine on this one? Okay, ramus perforantes. Ramus perforantes. So, anatomical variation A, textbook. Anatomical variation B, not in the textbook. Okay? But it doesn't matter because the artery is down in the V shape on the bottom. Okay? Down on the bottom in the V shape. Okay? Sulcus lateralis linguae, lateral lingual groove. Now, this artery supplies the salivary gland, supplies the muscle, supplies the periostome, and anteriorly there is a terminal branch. This is the terminal branch of the sublingual artery. This branch is coming out of the dense connective tissue and will go into the bone or will be just very close to the bone. This is very important when you do anterior mandibular surgery. Okay, we have spoken about this, but this is the mylohyoid muscle, the diaphragm. This is the salivary gland and the artery is here. So artery is far away, that's good. Okay, nerve here is very close though. Nerve here is very close. Okay. So, we have three zones. We have the lingual nerve, very close to the retromolar pad. The lingual nerve is 6 millimeters from the retromolar pad. The retromolar pad is a very important area, but we don't want to damage the lingual nerve. But if you don't touch the retromolar pad, our flap will be very short, because it's an anchorage, it's pulling it back. So we have to do something with this. We think there are three zones. Okay, first zone is the retromolar pad. The second zone, the mylohyoid muscle has a very oblique insertion. An oblique insertion. From the retromolar pad to the second premolar, the mylohyoid muscle is very close to the crest. Zone 2, the high mylohyoid attachment. More anteriorly, the mylohyoid muscle is far away from the crest, and there's a lot of periostome, and this is the low mylohyoid attachment. So three zones, the retromolar pad, the high and the low mylohyoid attachment. The mylohyoid muscle is very thin. So remember, we want three things: the bone graft, stability, and protection against the bacteria. And that's the main goal. So we developed the modified lingual flap advancement, or we call it the anatomically based lingual flap advancement. I have heard a lecture, famous lecture I invited here to Budapest, and he had shown a very similar case. These are perfect teeth. This is a 60-year-old, he showed a 40-year-old, and he said two things you can do for a patient like this. You can, he said, you can regenerate the posterior mandible using Photoshop, or extract all the teeth, cut the mandible, and put in 4 implants. We believe there are too many healthy teeth extracted. It has to be changed. It will change. In Europe, it's completely changing back. And now in the United States, there are some articles that to follow. Healthy teeth should stay. We have to learn how to regenerate. Photoshop. Let's take a look at Photoshop. So here's the patient with a thin phenotype. It's a thin phenotype, and as you can see here, hold on one second. Thin phenotype, narrow band of keratinized tissue. the length of the vertical incision. I measured about 20 surgeries, always about 10 to 12 millimeter long. So it's a long vertical incision, okay? Then, you have the retromolar pad. Once you hit the retromolar pad, you go sideways. Because if you go through the retromolar pad, you're too lingual. The mandible shifts this way. You go towards the coronoid process. Then, if your patient has a thin phenotype, you have to reinforce the incision to perfection so you can peel this off without any damage to the flap or the periosteum. You don't want to do any damage to the flap or the periosteum. Good. We do a mini vertical incision mesially. Now, I'm telling you this is very important. Why? Because you want to open this and you can control what you're doing. And the vertical incision will help you do. If you don't do a vertical incision, you do an envelope flap. You're like, okay? I'm telling you this because after this lecture, somebody's going to tell you, oh, no need the vertical incision. Yeah, you need the vertical incision, okay? To control the third zone. Then we elevate the flap. But here, the mylohyoid muscle was only 2 millimeters away from the crest. In fact, in a horizontal defect, it's 6 millimeters away from the crest. In a vertical defect, from 0 to 3. So sometimes you reflect and you hit the mylohyoid muscle. What do? Don't touch the mylohyoid muscle. You stop and you wait now, because now you're going to start to do the 3 zones, the 3 steps. The first step is you're going to go under the retromolar pad, you tunnel and lift the retromolar pad. Why? Because if you don't do that, it will anchor back, it will pull back your flap. This is safe because the nerve is 6 millimeters apical. You only lift it up. Okay? That's easy. Tunnel and lift. Second zone, second step. Look how close the mylohyoid muscle is. It's almost on the crest. And usually you see 2 to 3 millimeters, that's all. Instead of touching the mylohyoid muscle, what we're going to do is we separate the flap. We put a gentle instrument and we separate the flap. We call this the mylohyoid separation. We gently separate the flap from the muscle. See that? Gently separate the flap from the muscle. See? Muscle is intact, the flap is separated, the soft tissue, and up to the second premolar, we have a very, very good flexibility. We see the dense connective tissue. See the dense, sometimes we see the nerve or something. So this is all up. But look at the mesial part. The mesial part is down. Flap is up here, mesial part is down. Why? Because the mylohyoid muscle here is far away. And there's a long periosteum. So I have to do something here. We call it the scratch to bring it up. That's going to be the third and most difficult step, is the third step. First 2 steps is like, you learn it is 20 seconds. Okay, it's very easy. Okay, we use a step drill. If the bone is thin, if the bone is very, very defective. We don't want to use a straight handpiece. You use a step drill, use a straight handpiece, and the bone is very hard. The white thing is spinning. Your assistant, doctor, don't worry, it's not the nerve. Patient's like, what? Look what I'm doing. This is where I want the bone, but this is very thin, narrow ridge. I need more biology, so I'm going to have to put the membrane down here, not to here, to here. So I'm perforating here, because now with the narrow ridge, I need to bring a bigger membrane, more apical down. See? Narrow basal bone. Today, we print the CT scan. We even make a guide, so we plan before. You know how we do it. We even cut the membrane before. Then, this is a 150 micron membrane. I think it's going to come into Vietnam very soon. Okay? There is a 150. 150 is very soft. I recommend it for the anterior maxilla and anterior mandible. For the posterior, it's a bit more difficult to work with. The 250 micron, very easy to work with, but here, it's not good. Because it can be sharp, like a titanium mesh. So here you want soft 200 or 250. The perforated membrane that I'm using is 200 micron. Okay, I'm cutting one corner off. If the bone is narrow, I cut from the middle, this is the middle, a little bit more, cut this corner off, the mesiolingual corner. If the bone is wide, then I cut the middle. Okay, this is the narrow cut, narrow basal bone cut. I fixate on the lingual. Here is the mylohyoid muscle intact. Gonna mix. Put some bone on the lingual, put some bone on the crest, and put a lot of bone on the buccal, all the way up to the apical. Compress the bone. Cut the membrane back. Now, when I'm doing surgery, it's very important that I don't forget something very important. When you do something every day, maybe you forget something. So for the most important points, my main assistant, my chief assistant has to remind me. 4 reminders. 1, doctor, clean the tooth again. Okay? Before you put in the bone graft. Number 2, cut, make sure there is 1.5 millimeter distance between the PTFE membrane and the tooth. With the sausage, the collagen can touch, PTFE cannot touch. 1.5. So, yeah, I can carry back, but if I forget and I touch, infection or it's going to be a problem with the healing. Number 3, when I'm here, Look at this, graft around the nerve. Doctor, please check around the foramen and wash it out. Any particles from here, wash out. 3, 4. Please check all my sutures at the end. Okay. Well, maybe, I need one more suture, or maybe I forgot to do something. Okay, I really recommend you to do that. This surgery has 12 steps. And out of the 12 steps, 4 are detrimental if you made a mistake. Now, remember the mesial part was down, so now there's the vertebral incision. I'm going to scratch the tissue. I like you to hold the blade parallel to the flap. I'm going to hold the blade perpendicular to the flap. Don't do that. I do this with this surgery, but I'm going to show you other surgeries, but I'm going to hold it differently. See, this is almost 45 degrees. I think at parallel is a little bit better. With the back end of the blade. Okay, I wanted to stop. So, this 90 degree, I can do it because I've done it so many times. But here, on this live stream, I demonstrated. Look guys, I'm doing this and nothing happens. I only cut the periosteum. If I cut the periosteum, this will come up. This will come up. But I could hold this blade parallel. Like this. This is the flap, this is the blade. And just scratch. Just scratch. Okay, this is what we call the horizontal hockey stick. Now, how apical are you going to go? I'm going to also show that in another video a little bit more. But what happens is that the flap becomes like this. Okay? So I'm on the phone. Can you do it? Yes. Are you sure? Yes. Because to me it doesn't matter how big the defect is. Because there's no way I cannot close the flap. The flap doesn't bleed. See? It doesn't bleed. It's the dense connective tissue when 3 zones, anatomical zones, 3 surgical steps based on the anatomy. Now, on the buccal. The periosteum is less than 0.4, it's 0.375 millimeters thick, very thin. How deep will I cut? I cut 0.376. I cut only through the periosteum. Once I cut through the periosteum, but I'm not cutting deeper, it's like just scratching through the periosteum. After this, I have a cross arch. See this white bundle. What is that white bundle? That white bundle is a micronerve coming from the mental nerve. It has no biological function, but it's very resistant. So the second step, I take a new blade, I rotate it, and I play the guitar. You will see these bundles here and here. You're not going to see them here. Okay? You need loops. And you don't want to cut deep. You want to just debundle. Then you stretch. This is the third step. You take your little instrument, it's a mini instrument. My son. I have a genetic relationship with this instrument. I name it after myself. The name is Mini-Me. Okay? Now look at this. This is the nerve. Still covered, but if you cut deep, not good. You only scratch through you debundle, and then you stretch. You cannot use your blade. You shouldn't use your blade. And then you suture in 2 layers. Okay, and you wait. And now you graduated from Photoshop. Now, how many implants do I recommend you put in there? I recommend 2 implants and a bridge. 3 implants, or if you want 3 implants, they should not be connected. If they're connected, your patient has to have a very good hygiene because it's the most difficult to clean. This patient had no keratinized tissue. Now the patient is going to have some keratinized tissue, but I placed 3 implants, 3 parallel CCs. Okay, this one could be a bit deeper. Could be a bit deeper. Now I have keratinized tissue on the lingual, keratinized tissue on the buccal. How did I do it? When did I do it? I think it's very important. I'm going to come back to this, and we're going to discuss that also. They connected, the prosthodontist connected them, so this is the most difficult to clean, but it's almost 10 years in the mouth now, and it's still clean. But the patients, for our patients, we have 4 hygienists, and most of our patients come 4 times a year. If they come 4 times, they get a 20% or 25% discount on the cleaning. So most of our patients, they come in 4 times, all the time. They go to hairdresser, nail, cleaning. Now, this was easy. Look at this patient. Steep angulation. Steep angulation. Premolar. What should I do with this? I don't do anything. I don't extract this tooth. But maybe you extract. And the case becomes much easier. Okay? If it's a canine, you never extract. But this patient already had some bone graft failures. You want to do this. I have a lot of patients like this. I love it. Let's take a look at this. So, steep, steep, steep. I'm making a crestal incision in the middle of keratinized tissue. I go 2 teeth away. Very steep angulation. Here's the nerve. Tunnel and lift the retromolar pad, step 1. Step 2, separate the flap from the muscle. Separate the flap from the... Step 3, with the back end of the blade, scratch through the periosteum. This one, this gel what I applied, it's called Regen Fast. It's polynucleotides in a hyaluronic acid. It's not here yet, but you can put some growth factor. Okay, this is a very weak. It's not a growth factor, it's very weak, it helps a little bit. Okay? This one is a low, this is the small granules of the anorganic bovine bone mineral. I'm going to perforate through the bone. And I have a surgical guide now for fixation. Use the Profix screws to fixate. I have holes in the membrane now. And I'm going to put in the bone graft. Now I put 60% autograft and 40% xenograft because the defect is too big. And I'm going to put in a growth factor, another type of growth factor, the BMP2 microdose, very low dose. But then, I cut the membrane back far away. Now look at this. The tissue is white. It's white because this is a class 2 tissue. There are 3 types of tissue. Class 2 tissue is what? Fibrotic tissue. Okay? Patient who has surgeries before has a class 2 fibrotic tissue. At the nerve. Now, my flap is shorter than before. A little shorter because the defect is big. So I don't have so much flap. Instead, it's medium short. Now, where do you cut? Where do you cut? What I like to do, I make a scratch at the beginning. I try to keep 6 millimeters of a flap to here. Sometimes I can't. But I will make sure that I don't cut somewhere that is too thin. But I want to stay away from the nerve as far as I can. I don't want to cut here. So I want to go and make the incision somewhere here. Which is safer from the nerve, but not too close to the incision line. Okay, 6 millimeters from the incision line is very safe. 4 millimeters, more careful. I cut through the periosteum only. Then you see this bundle, 1, 2, 3, and the nerve is right under. Play the guitar, debundle, and stretch. See that? Very careful. Now, I stretch, but maybe this is not the final stretch. I stretch gently and stretch maybe 3 millimeters here. Maybe not enough yet. But if I stretch more, maybe too much force, pull the nerve too much. I don't like that. So I stretch gently, debundle again, stretch, debundle. This is what we call the gradual stretch. What is the gradual stretch? You make a little incision, debundle, stretch. Debundle, stretch, debundle, stretch, but no deep cut. It's also very important, when you elevate the flap, you don't go under the nerve. You don't elevate under the nerve. Why not? Because your assistant is going to stretch the nerve out to 10 millimeters and the patient will have numbness for 3 months. There it is. Stretch, stretch. Oops. Let me go back. Okay, let's take a look at this again. Stretch. Stretch, debundle. Stretch. Gradual stretch. Debundle. Debundle up here now. Away, and now I can stretch more. See that? Nerve is still covered. There's a lot of stretch. Good lingual flap. Good. Now I want you to see this case only for the lingual flap. Again. Okay, this is another cut of this. Fast forward this. Okay. First step. Tunnel and lift the retromolar pad. Second step. Separate the mylohyoid muscle, the flap from the mylohyoid muscle. Third step, scratch through the periosteum in the level of the mylohyoid muscle, as apical as the mylohyoid muscle, and then stretch the tissue up. And see that? Flap is very, very well stretched out. Good. Now, digitalizing the membrane. Digitalizing the membrane. How do we do that? Okay, so here you will see that we can pre-surgically place the implants. So what we do is that first we do a wax up. First we do a wax up. Once we have the wax up, we virtually place the implant in the DTX. So that's one software. Then we place the implants in the DTX. Then we export it to this software. Then we create a surgical guide to place the bone graft to perfection, to be able to fixate easier. Okay, raise your hand if you think the lingual fixation is difficult. Yeah, everybody always thinks that. Okay, this is going to make it easier. We're going to cut this back in a way that we need to have it with a membrane. We have the future implant sites prepared already, so we can use this as a surgical guide for the implants and for the bone graft. That's why we call it the master guide. This doesn't matter. Look at this. See that? You can have different types of design. Usually I get 3 designs because they print it. They print it for me. See, this one has no tooth, it's just the future holes for the implants. All you have to do is to microsuture the membrane in there. I don't like just to put it in there. I microsuture. It's very well fixated. Pre-cut. Then I put it in the patient's mouth. Click. Now I'm going to fixate the membrane lingual. Fixate on the buccal. I lift this up and I condense the bone graft all the way in. Condense the bone graft all the way in. Now look again, I'm going to go in the middle, make the periostal incision, the debundling and the stretch. And then I close. See, you can hear we have fully anatomical or just a cut-off anatomical. This is how you do it. Now, good. We have 3 types of patients for the mental nerve. A patient who has a normal native tissue, class 1 native tissue. And that's what I showed you so far. You cut through the periostum, easy. Periostum is native. Then you rotate your blade. You're going to rotate your blade. And the rotating blade, you're going to debundle. Your rotating blade, you're going to debundle. And then you stretch. Stretch the flap. Okay, the 3 steps. You see the nerve. You don't see the nerve. Nerve is somewhere there. Okay, the nerve is invisible. You have a perfect advancement without any damage to the nerve. See those little white clear things? Those are the fibers. Those are the bundles you wanted to eliminate. That's a class 1. What is this? Fresh cadaver. This is the bone, the periostum, and the micronerve is this, the mini nerve. Mini nerve. Nobody knows it's a nerve. This is only us we know now. Because we block section the cadavers. What is this white thing? It's a nerve. It's a micronerve, is not functioning here. The big nerve is below. Good. What if your flap is very short now, shorter. So you have to cut on top of the nerve. Top of the nerve. You cut here. How do you feel about that? Raise your hand if you think, I don't want to cut on top of the nerve. I don't think I'm very comfortable cutting on top of the nerve. Right? Not very comfortable. Okay? So, what do? You cut on top of the nerve if the flap is very short. Then, you debundle, cut, debundle, stretch 2 millimeter, debundle 2 millimeter, debundle 2 millimeter. Once you bypass the nerve, then you stretch more forcefully, okay? And all of a sudden, you cut on top of the nerve, you stretch the whole flap, and the nerve has no problems. The nerve is completely intact. Good. On this video, I want to show you two things. Number one, the lingual flap, third zone, with a very good angulation of the blade. Number two, the class 2 soft tissue, which is fibrotic soft tissue. Okay, now watch very carefully, because I think this is one of the best video clips on the world for the third zone. Okay, watch. This is the easier part. I'm scratching and I opened only this much. And I'm inserting and stretching it up. Inserting, stretching it up. And all of a sudden, very, very minimally invasive, I got all this on top. Now on the buccal, class 2, fibrotic tissue, white. Why? Patient had multiple surgeries, become white, becomes thicker. And around the nerve, here's the nerve, I want to stretch, but it's difficult. Difficult to stretch. I debundle, it's more fibers, more debundling, too many guitars. Debundle. I stretch. No, not good enough. Look at this white string, those white bundles. Behind, in the back, no problem so much. Much more problem around here. Now I stretch with a blunt instrument. Posterior, good. Let's come back to the nerve area, the mentoforamen area. But here, not very good. And here, see? Gradual stretch, gradual debundle. I debundle, stretch, debundle, stretch. Here, debundle again. I started here, debundled, stretched up here, debundle again, stretch more. Debundle, stretch, debundle, stretch. Fibrotic tissue, class 2 tissue. Okay. Good. Now, 2 implants and a bridge would be the best. Pawn sacrifice, steep. This tooth was not very good, I took it out. Then I'm doing a bone graft. And all of a sudden I got the ridge. I'm going to place the implants in here. I place 1 implant. This is a replace implants, Nobel replace. 2 implants and a bridge. And put the implant deeper, and it looks very good. Class 3 patient. Scar tissue and foreign body incorporation. Some foreign body incorporation, which can be particulated graft material, pieces of metal. You cut, and it's difficult to cut, it's like a stone. In America, in politics, they would say, what you have to do with this? They would say, make the tissue great again. Okay, how do you do that? You need to remove this part. There are two ways to do it. One is called the periostoplasty. Second one is the periostal excision. So what do you do? And I'm going to show you a case now. But first, I'm going to cut here, and I cut 5 millimeters away. Then I go underneath and I take this out. Take this out. Once I took it out, I debundle, stretch. Okay? But first, or this is periostal excision, periostoplasty, when you go under a little bit. Okay, let's take a look at this patient. Here, I'm cutting in the middle of nowhere. There's no keratinized tissue, no nothing. I'm cutting in the middle of the desert. Patient with a chin graft, ramus graft, hip graft already. I already fixated the membrane, did the bone graft, but it's very difficult to close. I almost cannot close it. Now, I'm going to sit down and I take 10 minutes, a normal flap, 2 minutes. Fiber optic flap, 4 minutes. Scar tissue, foreign body flap, maybe 10 minutes. Okay, maybe 10 minutes. So, see, it's the worst. Here's the nerve, metal pieces in here. I'm going to cut one in here, one in here, then I'm going to cut a little bit higher up here. Then I go under the periostum, plastic under the periostum. Now I'm going to do the periostoplasty. I go like this. I go like this. See that? I go like this. Then I bluntly stretch. And here is metal here, metal here. Metal here, metal here. And you cannot see the nerve. But now, this can come up. I can suture it all the way to the root for the floor of the mouth. And I can close it here. And then I can have all the way the bone. Because I couldn't have it. It's just because of the periostoplasty here. If you don't know this, forget it. Not going to be able to. And that's why in the literature there's only 4 millimeters of bone gain, because people don't even try this. There it is. Okay, how long is this going to last? Here's a mandible that I treated a long time ago. And the membrane. Now, what else can you do? You can have the digital guide, the master guide to place the membrane. You can have a free hand, and you can have a free hand and some tools. You can put a temporary pin behind the last tooth, temporary pin here, 2 pins on the crest, mesial and distal. And then it's much easier to fixate. Now, you can have a pin, you can have a screw. The pin, we use the Mazinger master pin. The screw, we can use a Profix screw from Osteogenics, okay? With a handpiece. I think it's going to come in also to this country. Okay, so here is a temporary pin. You hit it in the back, and then the lingual is much easier. There's only one difficulty with this surgery, it's the lingual fixation, which is not difficult at all, but people are afraid of it. There's a big advantage of this membrane over the mesh, the titanium mesh. There's a big advantage with the soft tissue handling and the soft tissue healing. Now, what is the advantage of a non-perforated membrane? If you have an exposure, it's much likely to get an infection. If you have the perforated membrane exposed, you will get some bacteria through the holes. Okay? So this is the temporary pin. Now, let's go back to this patient. Let's go back to not this one. Let's go back to this patient, this bone. And here it is. This X-ray was taken in 2003. And this picture was taken in 2003. This is a baby bone. I put the implant slightly deeper. When I uncovered, it's already white. Why is it black there? Because it's not mineralized yet. Baby bone. This is mineralized now. And I took a picture of this bone. So I opened the flap again, opened this flap, and took a picture. Why? Because I wanted to see 2003, this picture is October 2003. Then we restore the patient. And this is at 15, this is 20 years of follow-up. Now, this implant is, now we have much better implants than this. We have better restoration. This was gold. It doesn't, it's ear fitting. Look at the fit. I didn't do the restoration. It's not perfectly fitting, but this is close by this. Okay? So we have better restorative material, better abutment, better implants, but it's still working for 20 years. Good. Please look at this. This membrane is the new membrane, has some holes. Why? Because of blood vessels in the periosteum. Okay? To get more vascularization. And we found in an animal study and a human study that you get more vascularization and faster maturation of the bone. If you do this membrane, the advantage, your bone graft will be 2 to 3 months faster. But it is a membrane here, in the first 5 millimeters, a membrane for good adaptation. So it's a hybrid, it's not a mesh, it's kind of like a mesh. Good. Would you like to cover this with a collagen membrane? Collagen membrane on top of this? Yes? No collagen membrane? Yes, collagen membrane? I don't know, but I would like to know. See? So, last week we published a paper, JCP, Journal of Clinical Periodontology, about this topic. We took some patients and we sometimes randomly put a collagen or no collagen. And we measure the rate of complication, no difference. We measure the thickness of pseudoperiosteum and the effective gain, bone gain. And there was a difference there. Now look at this patient, had no collagen membrane coverage, and look at the pseudoperiosteum, it's thick. It's like a connective tissue graft. But the bone is good underneath. So we learned that it's not absolutely necessary to cover. But if you don't cover, sometimes you have this thick layer of pseudoperiosteum, this green, and almost no pseudoperiosteum if you cover. So we think it's an advantage to put a collagen membrane. But it's not day or night. Okay, it's not life and death for the bone graft. There it is. Impact of collagen membrane vertical augmentation using the titanium reinforced membrane is in the Journal of Clinical Periodontology. We measure this digitally, manually. Apparently the journals, they only ask digital now. And I think the clinical measurement, to me, is even better, but anyway. So, here it is. This is the old ridge, this is the new ridge. What is the future? We don't know, but there are different things you can have in the future. Okay, one thing is growth factors. I think the autogenous bone is very good, but it should end. We don't want to use autogenous bone. We want to use a biomaterial, growth factor, stairs, whatever. Just don't take bone anymore from the patient. Even I scrape, scrape. I don't want to scrape. So, we tested a lot of things. We tested BMP2 in the United States. What did we find with BMP2? Very expensive. Patient was swollen like this for 3 weeks. Bone was full of holes, so we didn't like it. But then we recognized the problem. Too much dose, too expensive. So we tested a microdose. First on animals, 0.1 milligram, very little dose. How much? That would relate to a human, 0.5 milligram, which would cost like the price of a collagen membrane, not very expensive. What we believe is that the growth factors in general, not only BMP2, used wrong. Because they put them in the middle of the bone graft, inside the bone graft, which we call a sandwich. But we found in one of our animal studies that the good cells for a growth factor, the stem cells, are in the soft tissue. Stem cells are not inside the bone graft, are inside the soft tissue. So, we did test the sandwich against the lasagna. What is a lasagna? 100% xenograft. And this was the osteogenic xenograft, and a 0.1 milligrams of BMP2. We used a perforated membrane. We found this membrane, by the way, you should all know that from the company. This membrane, which has a hose, was designed for growth factors also. Okay? It's not only for normal bone graft, it's optimal size of hole for growth factor. Okay? In Europe, there's a company who's making printing titanium mesh. One is huge opening, there's a lot of soft tissue growth. The new one is almost completely closed. It's for the past. It's not for the future. Future is this. Now, we only wait with BMP2 for 2 months. In a human, in 4 months, you're ready, you're done. This is a biomaterial only. In 2 months, it's low, so not much of a bone. BMP2 in 2 months only, you have a new mandible. But this mandible is a resorbable mandible. We want the biomaterial. Now look at this. When we put the growth factor in the middle of the bone graft, there is no bone in the middle, but there is bone outside, where the good tissue, the stem cells are here. It's touching the stem cell, bone. It's not touching the stem cell, no bone. Lasagna, it's bone everywhere. Actually, osteogenics, who's making this membrane, this membrane became one of the most well-studied membrane in the history. Okay, how can I do this on a human? This is a lasagna, look at this. 0.5 milligram of BMP2 on the bone graft, and I have in 6 months, I have cortical bone. Remember, baby bone, shred off, 3 months, no, this is immediately cortical bone on the top. Did I use some autograft here? Yes, I did. But what can I try to do without anything? Just the biomaterial and BMP2. This is my implant. I placed many implants for this patient, but I have perimplantitis after 10 years in the second molar. There's a trough here. There is 4 threads exposed on the lingual. Can you regenerate this? Almost impossible, isn't it? So what do you want to do with this? Polish, usually, right? What we do with it. But I have, this electrolyte system to clean the implants. So I clean the implant. But I'm lazy. Now scratch some bone, put the bone here, put another, then a titanium reinforced membrane. No. Lasagna, vertical sausage. Surgical time, 18 minutes. 18 minutes, I walked out. I put here some, this is a Bios collagen, just a xenograft. This is a collagen matrix with 0.4 milligrams of BMP2. The cost of this was 150 euros. Okay, not so much. Then pin here, like a sausage, but vertically. Closure. Let's look at the swelling. Not much swelling. That's another implant that is closed. See? Not much swelling. This is in 4 months. Let's go back in 4 months. What do you see if you use a biomaterial in 4 months? You see biomaterial. Sometimes you place the implant, biomaterial is moving, like some soft tissue there, right? Wobbling. 4 months. No autogenous bone. 18 minutes of surgery. The 4 threads disappeared. Cortical bone. You cannot see the biomaterial. Because the lasagna called all the stem cells to help come in and become osteoblast. 4 threads disappeared. Cortical bone. Cortical bone, almost to the crown. That's the machine color of the implant. I never had bone here. The bone should be here. Bone. Okay? Future, maybe. Maybe. What about this? Patient's coming, nerve is exposed. Nobody wants to treat the patient like this. Me either. When I'm looking at the patient looking at me? Okay, I'll do it. So I talked to the prosthodontist, look, give me a surgical guide because when I cut, I don't want to cut the nerve. I want to be more lingual to the nerve. Then, I'm going to be full thickness here, full thickness here, full thickness. When I see this, partial thickness up to here. Create an island. Periosteum on the nerve. Then, bone graft, bam, on top of this. That's the plan. Okay? Good. So we did it in the DTX software. Once I had it, I'm going to puncture here to mark. Mark. Then I go on the lingual. This is the palm. Full thickness here, full thickness here, full thickness here, partial thickness here. Island. Protecting the nerve. Thin it out. Do I need a membrane on top of this? Do I need a membrane? No. I think this is dense tissue. It's like a membrane. I pack some autogenous bone on it, then the mixture, lasagna on the top. Palm. Step 1, tunnel and lift the retromolar pad. Step 2, stretch. Separate the flap from the muscle. Step 3, scratch through the periosteum, parallel. Stretch it up. Flap, whoosh, comes up. Look at that flap. Beautiful. BMP2, microdose. Okay, BMP2 is not available in Vietnam. BMP2 is available in the United States, approved for what? Soccer and sinus. So this is off-label. In the European Union, is available for back surgery and orthopedic surgery, called inductos. So you can use it, but it's off-label. You can tell the patient, look, this is legally here for a different indication. Okay? So, let me give you an example. Every fifth, if on the word, every 5th medication the doctor prescribes to the patient is off-label. For example, you give the patient pain medication for diarrhea, okay? Okay, that's illegal? No, it's not illegal, it doesn't work, but it's off-label, right? Okay, because it's not indicated for diarrhea pain medication. It's the same thing. So I'm perforating. This is the white cut, white body cut. Look, it's easy. It's easy. If you have a screw, 100 RPM, bam, bam, pin, open as big as you can, it's it. No digital guy, no temporary pin. I can fix it in 20 seconds, so you have to learn it. And now we're going to put the bone graft on top of the soft tissue island. It's fine. Condense. I want cortical bone immediately on the top. Now, once you did the BMP, you don't want to put the collagen membrane on the top because remember the BMP needs communication, direct. Lasagna, direct communication. So, you lose money on the BMP, but you save money on the collagen membrane. Price is similar. Bone is day and night. I can tell you one thing. The company, the dental company who's going to get the first BMP2 worldwide for dental is going to win the game of regeneration. And there's a new BMP, BMP6. BMP6 is getting the last study this year in Europe and the United States, and they're going to get approval in Europe and the United States. And for cleft patients in Loma Linda for the last 25 years, they don't do bone grafts. They open, put the BMP sponge, close, done. It's connected. 4 months later. Last 25 years. Off-label. Is it? Yeah, it's off-label. Okay, so you stretch, you close. Good. Healing. 6 months later, I go back. And you will see that I already have some cortical bone covering islands of cortical bone. See that? There's some cortical bone already here. Some pseudoperi, some cortical bone that I can place the implant. Now, this is the tough one. Mental foramen double, flap very short, foreign body incorporation, class 3, scar tissue, scar tissue. Let me sit down here. No. This is what we have time for. That's better. Let me go back. Look at the CT scan. See? Oops, wait. Okay. Look at that CT scan. Nerve is here, there's another piece of nerve in here. Biomaterial. Steep, pretty steep angulation. Last tooth is a canine, there's no way you cannot extract that tooth, okay? It stays. But now we know how to do it. Now we understand. Look at that tissue, it's bad tissue. No keratinized tissue, biomaterial everywhere. Crestal incision, like a black clee slope. See that? Flap is very short, biomaterial, biomaterial, biomaterial. Step 1, tunnel and lift the retromolar pad. Step 2, separate the muscle, the flap from the muscle. Step 3, scratch, and then stretch. It stretches up by itself. You scratch through the flap, it comes up. All the way. 20 millimeters at least. Use another growth factor is the regen fast. Polynucleotides. Polynucleotides, imagine BMP as a V8 biturbo. Regen fast is very cheap. It's polynucleotides. They also act for mesenchymal cells. It's a 3-cylinder engine with a mini turbo. Bone is going to be better, faster, but not like BMP2, okay? And it's not so well investigated as BMP2 either. But it's good. I'm the one who plays the most on the world. I did the most cases. I did like 130 cases with this thing, and I can tell you, it's not going to make the bone worse, it's making better. Makes it better. We're going to do lasagna also. Now that helps. Surgical guide. Fixation on the lingual. Now, the flap is so short that I cannot even put in the bone graft. I have to advance this part of the flap now. Now the flap is here, it's only 4 millimeters. So I'm going to cut like 2 millimeters away from the nerve. Cut. Periostalplasty, debundle, stretch. Debundle, stretch. Okay? So now I not only debundle, stretch, cut, periostalplasty, on top of the nerve, debundle, stretch. Okay, look at this, because if you don't look at this, you're going to have to wait 25 years to see the next one. Okay? Because very few people have ever seen anything like this. 2 millimeters from the nerve. All into junk tissue. Periostalplasty. Very careful. Debundle. Stretch. See that? I can still do the final stretch once I place the membrane. So now I'm going to finish the membrane. Put the growth factor. Stretch it all up. Put the collagen only at the neck here, where you have like a little opening. Close in the middle first, then close the rest. Okay, a little microsuturing. Beautiful, isn't it? Okay, this patient is just coming next month to place the implant, but as you can see here, that's kind of like, look at this one. This one has less than 1 millimeter on top of the nerve. I'm going to fast forward this one. Okay, I want you to see again the lingual. Separation of the flap. Scratch. Stretch it up. The nerve is here. You can see the nerve. The nerve is very, very close. Less than 1 millimeter on top of the nerve. You can see here just the canal. Just the paper thin bone is holding the canal. Okay, this is the bone graft. Let's take a look. Remove it, and I have cortical bone. I have cortical bone. Okay, there is 2 millimeters are in the host bone of this. Okay, so I want to talk a little bit about, I'm going to show you this before the break. Okay, so now how will I do this? Okay, that's going to be the healing, but let's take a look at the bone graft. I'm going to cut through the skin. It's from the back of the patient. Hair is growing in the mouth. 15 millimeters of thickness, fat cells. I wanted to extract this tooth, patient doesn't want it, so I didn't extract. But it makes it, because the bony peak is lost there a little bit. And very steep. And I'm afraid of the fibula. Have you ever done, anybody has ever done a bone graft on the fibula? See? Ah. Look at it, fat, fat, fat. Fat. What is good in the fat? Full of stem cells. Lasagna. Full of fat. The bone is down here. You go all the way. Look at this. It's crazy. This down of fat. The bone is down here. Fibula. I cannot take this out. Nobody can take it out because this in here is still, there's a little gap here. So they have to keep the metal. One thing is good, there is no nerve. So I took some bone from the other side, real quick. Scrape, scrape, scrape. Look at that. 0.5 milligrams. Taking bone from the other side with a trephine. Mix. That's a small granules of the BIOS mixed with the autogenous bone. Fixate on the link, but don't put a pin. You put a pin into the fibula, goes in. I tried, don't do it again, okay? Just a screw. Now I'm going to perforate the fibula. I don't like this. Perforate the fibula. In my mind, what if I get an infection? An infection goes inside the fibula and we lose the fibula. Okay? If we lose the fibula, there's no fibula. We have to take another one. So, why? Because I'm going to suture the skin. And to suture the skin around the tooth, I don't like that. I'm going to do a papilla shift. Behind the last tooth, I want to have dental tissue. I don't trust the skin. So I'm going to put this in, but I'm going to stimulate the fat cells, stimulate the fat cells. I have a friend for 25 years, he's doing fibula. He says they tried all kinds of bone grafts, never worked, not a single one. Distraction, bone graft, all failed. But lasagna, I trust a lot. Lasagna on the crest, lasagna on the buckle. 0.5 milligrams. Maximum 1 milligram. Fixation. Now I'm going to close, easy to close, with so much tissue. There's no problem with the closure. But here, I want dental tissue. Dental, like gingival tissue. That's a piece of bio-guide in here, but I'm not covering the BMP2. And now, I suture the skin. There's some hair. I tried to pull out, but I can't pull out all of them. And now, see, I put tissue here, 1 millimeter, 2. So I get gingival tissue behind the tooth to get a normal attachment, because this will not give me an attachment. This was a live surgery. I was not very comfortable. I didn't know what to expect. There's, see, dental gingival tissue behind the last tooth. Gingival tissue behind the last tooth. The best bone that I've ever regenerated is this. I had to use a new drill kit because I couldn't drill. It's all cortical bone. It's all cortical bone. Bone was down here. Bone is up there. I sent this, the cancer surgeon who sent the patient from another country was like, I can't believe this. I sent a picture to my friend who's the fibula surgeon, the cancer surgeon, was like, wow, how did you do that? Okay, so, how did I do it? Research, right? Animals, lasagna, thinking about it. And this is all cortical bone. This wide, this high for the posterior mandible. So, we have discussed the posterior mandibular surgery. We discussed the anatomy. Okay, what do we have here? Who can tell me? 4 things. Sublingual artery, sublingual gland, lingual nerve, Wharton duct. All embedded in the dense connective tissue. Protected against the dentist. Okay, we learned in the lingual, we have 3 zones. 1, the retromolar pad, the high myloid attachment, and the low myloid attachment. 3 steps. 3 steps. 3 steps. Turn and lift the retromolar pad. Separate the flap from the mylohyoid, scratch and stretch the mesial. Around the buccal, we learned 3 types of tissue. Native tissue, easy. Periostal, just a periostal, debundle stretch. Done. Fibrotic tissue, more fibers. Periostal incision, debundle, stretch, debundle, gradual stretch. Type 3. Scar tissue with foreign body incorporation. What do? We make the tissue great again. How do we do that? Periostoplasty. Incision under the periostum, or double incision under, remove the biomaterial, debundle stretch. Okay? We learned about the lasagna. What is the advantage of the lasagna? You get cortical, nobody has ever seen bone graft like this in their life. Okay? Lasagna. So, yeah, that's the posterior mandible, but I have bad news. This was easy. What's coming after lunch is much more complex than this. Okay? Thank you very much for the attention.